then urine, it's not just all about the urine. Remember, we've got the kidneys that we're gonna be thinking about, the ureters, the bladder, the urethra, men versus women. If one thing goes wrong in the system, the whole system is affected, right? If the kidneys are not working well, we're not going to make proper urine. We're not gonna remove waste from the body effectively. If one of the ureters is blocked with a kidney stone, then you might not see the normal amount of urine output because the urine is blocked by that stone, and actually is going back up toward the kidney and can get the kidney inflamed. If something is wrong with the bladder, like maybe it's full of cancer, and the bladder cannot expand like it needs to, then we're going to have trouble. Good morning. Having urine coming out. If something is wrong with your urethra that goes from the bladder out to the outside of the body, maybe there's a stone that came down the ureter into the bladder, bumped around, and then came through the ureter, the urethra, and got stuck. Ooh, that would be terrible. And then no urine to get out. So the whole system has to work right for everything to work well. Okay. So in my notes pages for this slide, I've got a few things here. We've got drugs that can interfere with the function of the intestinal smooth muscle, because it is smooth muscle that wraps around the intestine and helps provide the peristalsis needed to move food and stool through the intestine and out. Some of those drugs would be anesthesia. General anesthesia, as you probably already know, puts the whole body to sleep. It's not just the person goes to sleep. Everything in your body goes to sleep. That's why they get put on a ventilator when you have surgery and you have general anesthesia, because nothing in your body is working. And it can take a while when they wake you back up and bring you back to your room before everything wakes up in your body and starts working again. Sometimes the gut can take a day to wake up good. That's why people cannot eat or drink after they have surgery until they have bowel sounds and are passing flatus, and we know the intestinal system is working. Then they can start eating food. Laxatives, we're going to talk about laxatives. You know what they do to gut. I don't need to expand on that. Opioids, like morphine, OxyContin. People who take those drugs often suffer from constipation because they slow the gut down. And you can get really constipated if you've been a week on pain medications. And that's something that we have to deal with our patients in the hospital. If we know we're giving them pain medications, we need to be assessing their bowel movements, how often they're having them, their bowel sounds, do they have bowel sounds, are they eliminating properly? And if they're not, we need to collaborate with the doctor and get something for that, like a laxative that we just talked about. Crohn's disease is just an example of an intestinal malfunction, and it makes the intestines not work properly. You may know someone that has Crohn's disease, and you know that they constantly have abdominal pain and diarrhea/constipation, depends on the day. Their little bowel system is just in a wreck. And then there are life events that can alter the integrity of the urinary sphincter, and we'll talk about some of those, like childbirth. For those of you who have had a baby, you know what it does to your bottom end, right? Anyone in here have babies? Yeah, good memories of that, right? You remember everything about it. Obesity, the weight of a big belly bearing down on your pelvic floor constantly can weaken your pelvic floor and make you prone to things like urinary incontinence. And of course, bladder cancer. So we have lots to talk about in these areas today. This is something that you'll need to just commit to memory, words to know. Defecation, fecal and feces, that means stool. Micturition is the process of urination. continence. Anuria, A before word means no, or nothing, or absence of. So anuria means they're not putting out any urine. Dysuria means painful urination. Polyuria means lots of urination. Urinary frequency, urinary hesitancy, and nocturia, frequent voiding at night. You'll see these words on the test, not in a definition, like you won't see what is the definition of defecation, but you'll see the word used, so you'll need to commit these words to memory, okay? Something easy to do. It's like being in an English class again. You got your box of vocabulary words. 1,000 words you have to learn, right? So we'll start with urinary elimination, and that starts on 312 in your book. So the urinary system, as you know, removes waste products from your body. That's one of the systems that can remove waste from your body. Other things that remove waste from your body in their own way, and their own specialty of waste, would be your lungs, your lymph system, your liver, your spleen, even your skin. Those are some things that all remove waste from the body. But the urine is important. That's something we look at constantly in nursing. We're always measuring patients' intake and output. We're always looking at the quality of urine, the character, the odor of the urine, how much it is, balancing that with how much they take in. So generally speaking, whatever we take in, whatever that amount is in fluid, if we're healthy, we should be putting that amount out. Output should equal input. There will be occasions when your output is more than what you take in, or there'll be occasions sometimes where it won't be as much as you take in. Those are the worries sometimes. You know, something is amiss if you're not putting out what you're taking in. So when we talk about urinary elimination, there can be alterations in that. Suppose you are an elderly person and you have urinary incontinence, and you still have a good mind, and you are aware that you have urinary incontinence, and you have to wear a depends. Imagine how that would make you feel. Or maybe you're a 24-year-old woman who is suddenly paralyzed in a car wreck, and now you can't take care of your elimination needs as effectively as you used to, and you have to wear depends. How would that make you feel? So we need to be sensitive to this when we're taking care of patients. You know, those of you who work in healthcare already, and for the rest of you, one of the things we have to do is round on our patients every hour. That means go to their room and physically put our eyeballs on them, go into the room, make sure they're breathing, make sure they're where they're supposed to be and not on the floor, make sure they're not in pain, make sure their call bell is in reach, all those things that you learn about in your safety unit. And one of the things we do as well is if they need help getting up to the bathroom, we offer to toilet them, offer to get them up and help them to the bathroom. So every time you round, you need to be asking, can I help you to the bathroom? Because a lot of times people in the hospitals and in the nursing homes don't want to bother the nurses because they're so busy. And so they'll lay there and lay there and lay there and not call for help. And then all of a sudden they've got to go. And then they're trying to get up and they don't walk well and their cane's on the other side of the room. And then what happens? We get a fall. And that shouldn't even happen. We have enough time in the day to round on our patients and ask them if we can help them to the toilet, and we should do that. And be very sensitive to their needs. So, we've got kidneys, we've got 2 kidneys, right? Most of us, some of us don't, most of us have 2. They remove waste from the blood and they form our urine. We usually, adults generally make around 2 quarts of urine a day. That is roughly 1,800 to 1,900 milliliters a day. Now, a great big person who's a 7-foot-tall basketball player with a big body might produce more than someone who's 5 feet tall. This is just an average. So don't think you're gonna see on your test how much urine does someone put out in a day, because you're not gonna see that question. However, you need to have it in your mind that we put out usually around 1,900 milliliters a day. So if you get a question that says a person has put out 300 milliliters of urine in 24 hours, you recognize that as a problem, right? Is that a concern or a problem? Problem. I just said it was a problem. Right. So just know what the estimates are, so when you read your questions, you'll be able to apply that to what's going on in the question. The ureters are what come from the kidneys and come down to the bladder, so we have 2 ureters. Then we have the bladder that holds the urine for us until it makes enough stretch on the bladder to signal to the brain that it's time to empty the bladder. And the urethra goes from the bladder outside of the body. The urethra is very short in women, usually only 1.5 inches to 2.5 inches, whereas in men it's typically around 8 inches. So because women have such a short urethra, what does that make us more prone to? UTIs, because it's a short trip for microbes to go from here to here. So what is the thing that we always teach our daughters when we're potty training? Front to back. You will never, ever stop teaching women. We had a lady in the hospital just last week that had a raging UTI, so bad that it put her in the hospital. And the organism was E. coli, and guess where E. coli comes from? Yes, comes from your poop. So you know how she got it, right? So my male student had to go in there and teach the female patient about wiping from front to back. And he was all aflutter about having to do that, but I made him go in there and do that, and he did a really good job. So you'll be doing that too with your patients. So, now, the bladder. We've got nerves on our bladder that when the bladder stretches, it signals those nerves. The nerves go from the bladder to the spinal cord. When the bladder stretches, the message goes through those nerves to the spinal cord up to our brain, and the brain says, "Oh, I've got a full bladder, it's time to empty it." And it sends the message back down the spinal cord to the bladder, gets us moving toward the bathroom. That's a beautiful system, unless the person has a brain injury and the brain never gets that message and can't do anything with it to tell that person it's time to empty the bladder. Or maybe the person is a paraplegic or a quadriplegic, and the spinal cord is damaged. The nerves down here on the bladder still work. The bladder still works, we're still making urine, but when the message goes through those nerves and up the spinal cord, it gets blocked by that damaged area in the spinal cord, and the message can't get to the brain. So what problem does that pose for the people who are paraplegic or quadriplegic? Yeah, they might not be able to feel when they have to go to the bathroom, so the bathroom gets over-distended, and then they become incontinent, or they don't feel the urge to go to the bathroom, and the urine sits in there and sits in there and sits in there. And what happens when urine stays in the bladder too long? It can start growing bacteria, and then they can get a UTI. Right, so these people have to learn how to self-cap in order to get that urine out of their bladder. So that's a teaching moment that we would have to do for those patients before they get discharged home, how to self-cap. And that means take an in and out catheter, go in several times a day, every 2 to 4 hours, and empty their bladder. And in the hospital, we do not reuse catheters. It's a one and done deal because we're lucky enough, we live in America, we have plenty of everything. We have catheters, it's a sterile procedure, we never reuse catheters. But at home, people who have to self-cath every 2 to 4 hours with an in and out catheter typically reuse that catheter several times. It's just a small tube. They clean it after every use, put it back in the package and reuse it. But on your tests, you know, the idea is that we keep a sterile procedure, we never reuse anything, unless I'm talking about a paraplegic who is using self-cath, okay? So if it doesn't say those words, then we are living in the ideal world where we never reuse catheters. All right.
Is that a sterile procedure?
It is a sterile procedure. Okay, so in the hospital, because we're using sterile equipment, it is considered a sterile procedure. And when you learn it up there in the lab, it'll be a sterile procedure. At home, when the person is doing it like the paraplegic, it is a clean procedure because they're reusing the tube they used before.
Okay.
And they'll do it as sterilely as they can, but by that time, it's just not sterile, it's considered a clean procedure.
Thank you.
But y'all will learn how to do it sterilely. So, looking at the system here, I have the notes page, so we're just I want to point a few things out on the notes page. So most of us, our kidneys are about 4 or 5 inches long, and the left kidney sits higher than the right kidney because our left kidney has to sit up to make room for the stomach and the spleen over here. The right kidney sits down a little bit lower to make room for the liver that's over here. So as you can see in the picture there, we've got one that's a little bit higher than the other. The kidneys are responsible for the removal of metabolic waste and other elements from the blood. The kidneys work best when they are perfused with about 1 liter of oxygen-rich blood per minute. So 1 liter is right much blood, right? Takes about 1 liter of oxygen-rich blood to get the kidneys to work perfectly. So what is a situation where a patient might not be getting a whole liter every minute? Can you think of a situation where that might be happening?
COPD.
Find out. Find out.
Okay.
COPD patients are on.
So think about, okay, so there we're getting warmer. Think about it as perfusion, right? The heart has to be pumping effectively to get a liter's worth of blood to the kidneys. What situation would the heart not be able to do that?
They have
They're
low
having a heart attack.
You have low ejection fraction.
Oh, yes, so low ejection fraction, not getting that blood out, which happens when sometimes a person is in shock, right? You've had vital signs already, right?
Yeah.
Okay, so low blood pressure. What is your lowest normal blood pressure? I don't know what y'all were taught. I was taught 90/60 is the hallmark. That's where we consider it still okay. What were y'all taught? 90/60? Okay. Well, I don't wanna mess y'all up. Okay. So, when a person's blood pressure is low, we'll just go with that, okay? When a person's blood pressure is really low, they're not going to perfuse effectively, and the kidney may not get a whole liter every minute. How do you think that affects the function of the kidney? It decreases the function, so in return, what will you see as evidence of a kidney not functioning well? Less urine, some swelling in the body. What might the urine look like? Dark, right, very concentrated, maybe cloudy. So you see where I'm going with this, right? If the person is not perfusing well to get blood to the kidneys, the kidneys cannot do their job effectively. And so the waste products from the body are not going to be eliminated like they should. So if I gave a person some morphine for pain, and it's supposed to be excreted from the body completely within 6 hours, if the kidneys are not perfusing well and not putting out the adequate amount of urine, is that morphine going to be excreted from the body fully?
No.
So what's gonna happen if I come along 6 hours later and give another dose of morphine to that patient? Now they're gonna be like double dosed, right? They're gonna become toxic, and they're going to feel the effect of that morphine much more strongly. So the whole idea about kidneys putting out urine and removing waste from your body is directly connected to whether or not the person's heart is working well and perfusing blood like they should. So we want to see a person's urine output to be at least roughly 30 milliliters per hour in the adult. Now you just had fluid and electrolytes. Did you learn like 0.5 milliliters to 1 milliliter per kilogram per hour?
Yeah.
Okay, that's right. And if you measured up a person's weight, by the time they get to be an adult weight, that's going to be roughly about 30 milliliters per hour. So either one of those calculations will get you where you need to be. So if an adult should put out 30 milliliters an hour, then in 8 hours, how much urine should they put out? 240 milliliters, that's right, in an 8-hour shift. So if you go to measure someone's urine at the end of the shift and they only have 50 milliliters of urine, we've got a problem, right? That's not a concern, that's a problem. Because that means those kidneys are not working like they should. Okay, good. And then I've got down here, it starts talking about nephrons. So each kidney has around 1 million nephrons in each kidney. It's a lot of nephrons. And the nephrons are those little units that help actually make the urine. So if a person has kidney damage for whatever reason, maybe it's kidney cancer, maybe it's acute kidney injury, or maybe they have kidney failure, and the nephrons begin to die off, are they going to be able to make urine?
Not as bad, not as well.
Not effectively. So that's why you see people who have kidney failure, they produce very little urine. People who are on dialysis make very little urine on their own, and some don't make any urine at all because their nephrons are just gone. That's why they have to have dialysis. So we have to protect those nephrons as best we can. There are some medications that are considered nephrotoxic, means they're harmful to the nephrons in the kidneys, like your myosin drugs like gentamicin and vancomycin. And that's all you need to know about those two drugs right now. If you see the, bless you, if you see the name gentamicin of drug on your test, automatically know that that's a nephrotoxic drug.
How do you spell that?
Gentamicin.
And you said what was it used for? What was it used for?
It's an antibiotic. And vancomycin is also an antibiotic. Now there are other drugs that are also nephrotoxic, but those are the two examples I'm going to give today. VANCO and then mycin, MYCIN.
That's a quick question.
Mhm.
Is that why they do vein troughs?
Yes.
Okay.
So they do vancomycin peak and troughs and gentamicin peak and troughs around the 5th dose. Those antibiotics are given IV in a little piggyback bag. They drip into the vein. And they have to draw labs around the 5th dose to make sure that the patient is getting the correct amount of medicine. And if they don't fall within the range they want them to be in, if they draw a gentamicin level and it's too high, that means the dose is too strong for that patient. And it's probably damaging their kidneys, so they have to decrease the dosage. And if they draw the level and it's too low, that means they're not getting enough of that medicine and they'll increase the dose. So you will learn about peaks and troughs at a later time. But since it was brought up, I went ahead and mentioned it. But just know that gentamicin, vancomycin are antibiotics and they're nephrotoxic. So if we have an elderly person who is already experiencing a decreased blood flow to their kidneys because they're elderly and they generally have a reduced blood flow to their kidneys. So we're already worried about kidney function already. And then that elderly person comes in and the doctor prescribes gentamicin for them. We really, as nurses, have to be on top of that and monitoring their intake and output, monitoring, now what labs did you learn or your renal labs?
The bun and creatinine.
BUN and creatinine. So you did learn about that in your fluid and electrolytes, right?
They touched on it.
They touched on it. So your BUN and your creatinine are two labs that are considered your renal labs. And I'm not gonna give you values right now because, again, that's coming up in another lesson. But if you know that's a renal lab, if you have an elevated creatinine, what does that suggest? Is that good or bad? Bad. That's right. So we don't want a creatinine that's too high or a BUN that's too high because that means the kidneys are not working well. And consequently, the patient's probably going to be putting out less urine than they should and not filtering their blood like they should. The urine may come out looking very concentrated. What does concentrated urine look like? Dark, right, that's right. Oh, I like teaching this after you've had fluid and electrolytes because you already know some things, that's good. Okay, so moving down the notes page, we start talking about the detrusor muscle. So the bladder is wrapped in this muscle, a smooth muscle called a detrusor muscle, and the muscle go up and down on the bladder and all around the bladder. And typically the detrusor muscle stays relaxed so that the bladder can fill up, and then once the bladder gets to be a certain fullness, it signals those nerves that go to the spinal cord, that go to the brain that says I'm full, and the brain sends a signal back down to the detrusor muscle and it goes, whoop, I'm full, I need to go to the bathroom. And so that helps us know, yeah, I gotta go to the bathroom. And it's important to pay attention to those signals. If you need to go to the bathroom, you don't need to sit there and hold it for 2 hours. You need to get up and go. Because if you sit there and hold it and hold it and hold it, it's going to start working against that detrusor muscle, and you may end up down the road with having a weak bladder or a weak detrusor muscle, and then you're going to struggle with urinary incontinence and urinary urgency. And nurses are the world's worst because we're working a 12-hour shift and we're so busy, and it gets to be lunchtime or 2 o'clock in the afternoon, and you go, hey, I hadn't even been to the bathroom since I got here this morning. That's not good. We should take a minute to go to take care of our business, okay? All right. Then down at the very bottom of the notes page, it talks about the elderly client. By about age 80, the perfusion of blood to the kidneys is reduced from 1,000 milliliters per minute to about 600 milliliters a minute. Just because they're elderly, their heart might not be functioning as well. So they've got reduced blood flow to the kidney, which is not a problem in itself because the kidneys are still able to do what they're supposed to do. It's just they don't have any reserve left over if something bad happens. Like they get a nephrotoxic drug. All of a sudden now that combined with the decreased perfusion to the kidneys, they really are sitting ducks for having problems. So things to just kind of think about when you're taking care of your patients in the hospital or in the nursing home, and for the RNs, things that you might want to teach your patient concerning your renal system. So, this slide has a line through it. Anytime you see a slide of mine that has a line through it, that means I'm not testing you on anything on this slide. But it's good information to know because the as you see here, the kidneys do other things besides remove waste from the body. So I gave you a little smidgen of some other things kidneys do, but I'm not gonna test you on that, okay? So you can read about it. I've got some things on the notes page for you, things to know. Okay, so the act of urination. We've kind of talked about this already. You've got the word voiding first and foremost. Let's talk about the word voiding. It's kind of a funny word. A lot of people say, why does somebody come and ask me if I have voided? Well, what does void mean? It means nothingness, right? If you look into a vast empty space and it is void of trees, that means there are no trees out there. So to void your bladder means to empty your bladder. So we'll ask a patient, have you voided today? And they'll say, what do you mean? You have to say, have you emptied your bladder today? Or when you talk about this to the doctor, you'll say the patient has voided 2,400 milliliters in the last 24 hours. Okay, that's medical speak. So, we've got the stretching of the bladder wall signals the message to the nerves coming from the bladder to the spinal cord, goes up to the brain. Impulses from that micturition center in the brain respond by either telling us to ignore this urge or to go to the bathroom. That's what gives adults voluntary control over their bladder. We can either hold it or we can go to the bathroom. That's because our micturition center in the brain is fully functional. Unless we have a head injury that damages that, right? Or a brain tumor or something that's affecting that micturition center. That's also why little children who are not neurologically developed yet, it's hard to potty train them. So most of the time we say that little children we don't need to even try to potty train them until they're 2 or 3 years old because their brain is just not neurologically developed enough to do that. Now, are there some kids that potty train sooner? Yes. Are there some that take until they're 5 to potty train? Yes. On average, most children somewhere between the age of 2 and 3 can potty train. Urinary elimination control comes first, and then bowel control comes later. If you've raised kids, you know that they can potty train with their urine a lot earlier than they can potty train for bowel. That comes later. But 2 or 3 years old is what we're going for there. Some bladder facts just to remember. So the bladder capacity for most people is around 600 to 1,000 milliliters of urine. That's just for most people. I have put Foley catheters in people and gotten out 2,000 milliliters in one lap. So yes, the bladder can stretch more than 1,000, but for most people, if we get to be up to 1,000, we're gonna be going to the bathroom like this, cause it's like we got to go. So things to remember, so if you see it in a test question, you might see something that makes you think back to what's normal, because the test question will probably be a finding that's abnormal. The bladder stretches. Adults normally void every 2 to 4 hours. If we have the ability to do that and the opportunity, that's typically what we'll do. Most of the time, as it says in our notes pages, we'll put out maybe 2 liters of urine in 24 hours, around 2 liters, sometimes a little more, sometimes a little less. Muscles that support the bladder, our pelvic floor muscles, may suffer from stress if we are obese, or if we have delivered lots of babies and our pelvic floor muscles are weak. And so people in those circumstances may have some stress incontinence, which means if you sneeze, you may void a little bit. Or if you pick up something heavy, you may find that you void a little bit. That's called stress incontinence. So we can teach our patients how to combat that by teaching them how to do Kegel exercises. Have y'all heard of those before? So Kegel exercises help strengthen the pelvic floor muscles. And Kegel exercises are not really talked about a whole lot in your book. So in a couple of slides from now, I have how to do Kegel exercises. So you can learn about that, so you'll know about that for your test. A normal bladder does not leak. So a lot of women who have lots of babies will say, yes, I have some stress incontinence, I leak a little bit, I wear a pad, that's just me, that's not normal, okay? An elderly person who has to wear a pad because they have some incontinence, they live their life that way, but that doesn't mean it's normal. So we have to remember that as a nurse. If they're wearing pads and things, pay extra attention because they need to be cleaned more often, they need to be toileted more often, we need to keep up with their output. So this is a good time to talk about drinking. How much did you learn in fluid and electrolytes that an adult needs to drink every day? I heard a bunch of things. Did y'all hear 2 to 3 liters a day? Y'all didn't hear that? Did you hear 6 to 8 glasses a day?
Yes.
That's what y'all heard? Okay. Should we tell our elderly patients to drink less so that they don't become incontinent?
No.
That's correct. We never tell someone to drink less. A lot of older people will do that because, especially at night, because they don't want to have to get up and go to the bathroom at night because it's hard for them to walk and become mobile. So they drink less. So what's the problem with that? Yeah, they become dehydrated. What happens when you become dehydrated?
You become real disoriented if you let it get that bad.
You can, that's right. It also can lead to constipation, which we're gonna talk about in a little while. Lots of bad fallout from that. So we never tell our patients to drink less in order to not have to go to the bathroom as much. We always want them to drink the appropriate amount of fluid a day. Okay. So let's talk about this question right here. Right here. So you've heard the word cues, right? So nurses talk about cues. That means assessment data. What little things are we seeing in our patient that tells us that there's a problem? What cues do we see? What do you think would be some cues in this woman? Oh, her stomach could be distended, right? You can literally see that. You can literally see a bladder sticking up from someone's belly. Definitely, you can see that. That would be a big cue. What other cues might you notice? It might not be something visual.
Abdominal pain.
Like? Right, so she's gonna feel pressure, she's gonna feel uncomfortable. What kind of data is that? Subjective or objective? Because she said it, that's right. Your objective data is what you observe. Subjective is what the patient tells you. What other cues might you notice? When you have to go to the bathroom and your bladder is full, what are you like? Can't stay still, you're anxious, you're impatient, it's like, come on, we gotta go. Right, irritable. What's your heart rate and blood pressure likely to be like? Maybe a little bit elevated. If they were on a monitor and you could see their heart rate and blood pressure, it might be a little bit elevated. That's a cue. Like, what's going on here that's making this happen? Right. Okay. What about this one?
See if they use the bathroom yet?
Yeah, Yeah, but then you say that medication causes them not to urinate?
A nephrotoxic medication can damage the kidneys.
Right,
And so as part of that, they may be, I don't think it would immediately cause an abrupt halt of urination. It's a gradual process. So you might see that they're urinating less than they should. What other data might you notice if their nephrons are being destroyed? What are those labs? BUN and creatinine might be going which direction? Okay. Good. All right. So, some factors affecting urination. Growth and development, because we just said, what was the thing we just said about children? They're not neurologically developed enough to control urination until they're around 2 or 3. Most kids, some kids can do sooner. Different disease conditions, we've got cancer is one of them, kidney cancer, bladder cancer. Medications, what's the one medication most of you already know about that affects urination? Lasix is a, what kind of drug? Diuretic, and makes you go. It makes you go to the bathroom, absolutely. Different medical procedures can affect whether or not you're able to urinate effectively. One of those procedures that your book talks about is called a cystoscopy. So a say it really fast. Cystoscopy. You have to say it fast to get it out. That's where they take a scope and run it up your urethra and look inside of your bladder, and they can take a tool and go up in there and get a biopsy of your bladder if they need to. So a cystoscopy, if they run a tube up your urethra, what's likely to happen to that urethra? It gets stretched, it gets irritated, and then it becomes a little bit inflamed. Then they take the tube out and send you back to your room, and next thing you know, next time it's time to go to the bathroom, you might find it a little bit difficult to go to the bathroom because your urethra is a little bit swollen. And it's probably a little bit sore, so when you try to go to the bathroom, it hurts a little bit. So that is a medical procedure that your book talks about. Your diet can affect urination. What happens when you eat watermelon? You gotta go to the bathroom, right? Socioeconomic factors, such as the lack of a bathroom.
It's a bad time.
That's a bad time?
It's a bad time when you get locked up.
Yeah, it's a bad time. You've been on the road, you're traveling, it's 30 miles to the next city. You've got to go to the bathroom. Anyone ever get out of the car and go in the woods? Okay. Sometimes you're out there and the birds are chirping and it's like, I just can't get it to come out, right? Yeah. Right. Yes, and so sometimes the lack of a bathroom can have something to do with that. Psychological factors, such as anxiety and stress. I guarantee you on test day, you may have just been to the bathroom, but as soon as they say you can begin the test, it's like, you gotta go to the bathroom again. That anxiety just hits you and you feel like you have to go again. Fluid balance. You have a lot of fluid, you need to go to the bathroom. So, nocturia means what? Polyuria means lots and lots of urine. Anuria means, and oliguria means a small amount, like scant. So, you know, if you're weaning down to no urine, you're gonna have polyuria first, lots of urine. Oliguria means you're still putting out some, but not much. And then anuria means no urine at all. Diuresis means the act of putting out lots of fluid. So when we take Lasix, which is a diuretic medication, it makes you diurese. It makes you put out lots of urine. And that's an expected finding that we should see when we give somebody Lasix. Fever can affect your urination. Fever does a couple of things. It dehydrates you so that you put out less urine, and fever causes your body to produce lots more waste byproducts because you've got a really raging fever because your body is sick. Your body is fighting off infection and killing your white blood cells or killing bacteria, and your body just has a lot of extra waste products in it. All of that goes through your blood and has to filter through your kidneys. And so the urine that you produce when you have a fever is often very dark and concentrated because it's got extra metabolites and things in it that you don't normally have. That's why your urine looks very dark and it's a small amount. So fever can affect it. So on pages 276 to 278, just look at that. This is in the concept section of the book. There's a section that says factors affecting urinary elimination. You see that? On page 276. So I would go through and read this section. Under that, you've got on the next page fluid and food intake, muscle tone, psychosocial factors, pathologic conditions. Turning the page to 278, you've got surgical and diagnostic procedures and medications. And under the medications, just the diuretics that I want you to read about. We're not going to get into those other ones that are listed. But this is definitely something to read when you're reading about urination. Factors that affect urination.
So why do people get kidney stones? Is that like it's not a bacteria, why people get kidney stones?
Kidney stones are typically made out of calcium, and they're produced in the kidney as, you know, if you have high calcium levels or you're eating a lot of foods that contain high calcium, it all filters through your kidney, right? And then you got all that extra calcium coming into your kidney and it makes a stone. And then you know it. Kidney stones are horrible. They are worse than labor. All right, so we're going to talk about, I've already talked about this a little bit. With advanced stage comes weakened floor pelvic muscles. And what exercise are you going to tell your patients to do? Yes, that's right. Can men do Kegel exercises? We all can do Kegel exercises, yes indeed. And then the very young, so we've already talked about that as well, so that's good. So medical interventions affecting urination. I got fill in the blank, but it doesn't do any good because I'm giving you the answers on the notes page. A long time ago, I didn't give y'all the notes page. So, restriction. You're not looking at the notes pages? Okay, that's okay. Restriction of fluid intake, like being empty after surgery, will lower, of course, your urine output. Stress about the upcoming surgery causes, I've got fluid retention, but you can also say in parentheses, urinary retention. It does cause fluid retention in the body, but it also can cause urinary retention. Some medications cause increased urination, like Lasix. Some medications change the color of urine, like vitamins. Make sure urine look bright yellow, right? Vitamins. Diagnostic examinations causes localized trauma and edema. Patients may then have difficulty voiding. All right, so I've got 5 till 9. Let's take a break, come back at 5 hours.